Well, I will repeat that sentence because I'm introducing Ben Lacey, and I'm happy that you can be here today and present the UK Biobank. Ben is a physician by training and has been working since 2015 at the Population Health Department of Oxford, where he is now an associate professor. And one of his, or even his major focus, is the UK Biobank. And I'm very happy that you're going to talk about which data are available through the UK Biobank, and how it can be accessed. So I would like to hand over to you, and not to distract everybody, I will also turn off my camera, and then I will also be back to moderate the discussion. And after the talk, which will be about 20 minutes long, we will have another up to 20 minutes for discussion. So thanks, Ben, and I'm giving over to you.
Thanks, Eugenie. And yes, it's a pleasure to be here. I understand that I'm one of the first kind of non-German people to speak about a kind of cohorts or data in general. So yeah, very kind of pleased to do that. So as Eugenie said, I've been given the task of describing what's becoming kind of increasingly complex study and the access procedure in 20 to 25 minutes, which is a bit of a tall order, but I'll do my best, hopefully, without rushing too much. But I think we've got a good time afterwards for any questions that come up. So if there's anything that needs further clarification, please do let me know. So just to start as a kind of overview to UK Biobank, it's a prospective cohort study of 500,000 adults, and it was established with these kind of very broad aims to understand the causes of disease and therefore inform prevention, diagnosis, and treatment. But because it's a kind of cohort study, there's a particular focus on common diseases. But because of its size, it's becoming increasingly valuable for diseases that are often considered uncommon. The aim was to kind of combine a few characteristics that would really enhance the scientific value of the study. So to make it as very large, as I said, 500,000 participants, with deep characterization of both the exposures and the outcomes, to follow up participants for their health events for a long period of time, so thinking in terms of decades, but also to make it accessible as far as possible for researchers worldwide to conduct health-related research in the public interest. So it was at a time when these types of studies tended to either be very large and quite simple in their the amount of data that they kind of collected, or they were kind of relatively small and very deep. And there was a feeling that actually what was needed was to kind of bring those together. So I'll just talk about each of those key characteristics of the study in turn. So in terms of large, UK Biobank recruited participants of middle age, so they're between 40 and 69. And that age bracket was chosen as a kind of pragmatic age group where previous studies had indicated that you could measure exposures in most people before the onset of the disease, but that it wouldn't be too long before a large proportion of the participants had a health event. So that's the reason for that age range. They were recruited between 2006 and 10. Most of the participants are from England, but also there's some from Scotland and Wales. There were 22 assessment centres that were set up around the country, and participants that were registered with the NHS were invited to attend those assessment centres. And overall, about 9 million invites were sent, of which 500,000 attended in the end. There was extensive baseline collection, and I'll tell you a little bit about that in the coming slides. But importantly, there was consent to access their medical and health-related records. and to recontact participants for resurveys. So that's large. In terms of deep, the baseline questionnaire, we knew that it was important that we had the large number of participants. And so to do that efficiently, it was really important to kind of cut down the baseline assessment as far as possible, but include everything that we felt was particularly important. So the assessment took 2.5 hours in the end. It involved a web-based questionnaire with a range of information that was collected from the participants in terms of this touchscreen system. There was then a kind of set of tests and physical measures. There was a kind of a test of kind of cognitive, there was a kind of hearing test, and then together with some physical measurements, blood pressure, anthropometry, and a range of others, as well as sample collection, in this case, blood, urine, and saliva. So there's over 15 million aliquots in the end that were taken for long-term storage. On average, participants were just over 50 years of age. There was slightly more women than men. Most were of white ethnicity, which reflects roughly the proportions in this age group in the UK at the time. That's kind of quite different in the UK now, but that was kind of roughly equivalent to the kind of census before this study. And they were from a range of socioeconomic backgrounds, but on average, slightly more affluent than the population at large. And then, as mentioned, participants were consented for recontact. So there's been a series of enhancements over the last 15 to just under 20 years to really get more information on some outcomes and exposures that we knew it was going to be difficult to collect through the routine record. So an example is dietary questionnaire. To complete a kind of dietary questionnaire takes a long time, quite a bit of thought. We knew that we weren't able to do that in the baseline, but we could do it if we sent participants an email and asked them about their diet. Equally, there's things like pain and mental well-being that isn't well recorded in our electronic record in the UK, but is nevertheless really important for people's health. So we've had a range of those questionnaires and they're ongoing. So physical activity, we asked people about self-reported physical activity at the baseline questionnaire, but then we knew that getting an objective measure was going to be valuable. So we had 100,000 participants were invited to take part in this sub-study where they had a wrist-worn accelerometer. They wore that for 7 days, and then they sent it back to UK Biobank. And then for 2,500, that was repeated 4 times over the course of the year. And this is starting to be a particularly rich data set for understanding objective physical activity amongst our participants. Another enhancement has been our resurvey. So fairly soon after the baseline survey, there was a resurvey of about 20,000 participants, and that was to assess for short variation over the short term in the measures that were taken at baseline. So our researchers could correct for regression dilution. There was also a multimodal imaging study that was then started after the repeat assessment, and that included a MRI of the heart, brain, and abdomen, a full body DEXA scan. So that's a scan that looks particularly at distribution of body fat and bone density, carotid ultrasound, a 12-lead ECG, and then from 2019, a cardiac monitor. So those participants who were over 65 were invited to wear a cardiac monitor that was worn on their sternum. They wore that for 2 weeks and then sent it back to UK Biobank. And then we've also been kind of very fortunate to receive funding for a repeat imaging study. So of those 100,000 that's going to be imaged eventually of the multimodal imaging, 60,000 of those are going to be invited back, and we've reached about 10,000 so far. So from the onset of the study, genetics was seen as a kind of particularly important exposure to assess. That field has advanced much more quickly than I think the people who set up the study anticipated. So we had genotyping on the whole cohort available by about 2017. Whole exome sequencing followed a few years later, and then whole genome sequencing on the whole cohort has been available since the end of last year. And that's really been made possible through government and charitable funding, but also consortia of companies coming together and saying, this is very expensive. If we all kind of contribute some, then we can get this. We can get this done. So in addition to the genetics, there's whole cohort analyses of hematology, biochemistry, and leukocyte telomere length. So that's the kind of bit at the end of the chromosome that's believed to be associated with aging. And there's also assays on subsets for metabolomics. That's using the Nightingale platform that's predominantly lipids, proteins or 3,000 proteins in just over 50,000 participants, and also some infectious markers in 10,000 participants. And we now have funding to complete the metabolomics and the proteins on the whole cohort. So this kind of process of doing a pilot study followed by a large subset really illustrates the value of some of these measures, and then to eventually do it in the whole cohort rather than have a more a model where you get in-depth information on a very, very small subset. The idea has always been to wait until the costs of those assays come to a level at which they could eventually be done in a very large subset with a view to doing the whole cohort. So in terms of the kind of duration of the study and follow-up for health events, the study has been collecting health information since the baseline. For a study of this size, really, the only way of doing that in the UK is through linkage with the National Health Service and other national data sets. So we have linkage to the death registry and cancer registries, but also to hospitalizations that are collected locally, but then collated centrally by NHS England and the equivalent system in Scotland, and primary care on just under half the cohort. We're hoping that the other half of the cohort will have data on the other half of the cohort in the not too distant future. So we now have a number of conditions with over 10,000 events. The average age of our cohort is just over 70. So the number of events that are happening is increasing all the time. There are various plans to try and improve our health outcomes, and I'll just touch on those now. So we've kind of divided the kind of future plans on this slide into those that would enhance the risk factor characterization particularly, and those that would do the outcome. So in terms of the risk factor, we're going to keep doing those assays. There are more assays that we would like to do in the blood. We'd like to have a repeat assessment amongst all of our surviving participants. As mentioned, they are now just over 70. So this is quite a different cohort. And those who are particularly interested in aging and healthy aging, there are things that we would collect from our participants now that wouldn't have been worthwhile 20 years ago. So there's an idea to do a repeat assessment and possibly a first degree relative recruitment. And in terms of the outcome, there are lots of data sets that are collected nationally that we know would be valuable either to identify particular conditions or to better characterize the conditions that we have. An example is cancer histopathology, which the histopathology slides are collected by the hospitals. We know that a lot of them are now digitalized. If we could incorporate them into the data set, that would allow researchers to understand subtypes of the kind of histopathological subtypes. There are also conditions that we know that actually we probably need to go back to the participants to get some additional information. An example is kind of brain health. Dementia isn't particularly well characterized in the routine record. There's a sub-study that's underway that's trying to think about how we might collect the information that would help researchers to subtype the dementia amongst our participants. And lastly, are there novel ways in which we might collect information, such as through apps? So this is the range of linkages that are collected nationally that we know would be really valuable to researchers, and a lot of these we have and we're processing. So lastly, I just wanted to describe the access principles and procedures, as this is something I know that was of particular interest to the audience. So UK Biobank was always conceived that it was going to be an open access resource, and it's available to bona fide researchers to conduct health-related research in the public interest. That's the kind of core requirement and the consent by which we got from participants. It's available to academia or industry on an equal footing, and there's no preferential or exclusive access. The only caveat to that is where groups of researchers or companies have invested a lot of their time and funding to enhance the resource, in which case there's an arrangement for an exclusivity period for a few months, and then the data gets released to the whole research community. In terms of the application process, there are 5 key steps. We've tried where possible to streamline this, but there's always important that we collect enough information and we do enough checks to make sure that the data is going to be used consistently with the consent that we have received it. So I'll just take you through each of those over the next few minutes. The first step is to register as a researcher with UK Biobank, and there's a QR code here that will take you through to the page that you can do that on. We ask researchers to provide us with a list of their publications, their email account that's associated with their institution, and then some information to ensure that their conduct has been appropriate, such as details of consent. And that's to reassure us that this is a researcher who's a genuine researcher who would be interested in using the data for research. We also ask them for information on the institution to check similarly that that is an institute that conducts health-related research. That's reviewed by our administrative team and, where needed, our scientific team. Our researchers then are asked to submit an application to access the data, and they can choose either to access the data or to apply for access to our sample. The process for accessing the sample is much more complicated, so I'll just focus here on the data application. The form isn't too long. It just contains the essential information that we need and that will provide us with confirmation, really, that the data is going to be used in the way in which it's supposed to. So a project title, an outline of the research that they're intending to take, confirmation that the data is going to be used for health-related research, and a description of how that's the case. and likewise that the research is in the public interest with a description of how that's the case. We also ask researchers just to clarify whether or not the intended research might be considered contentious in some way, in which case we ask them to make that clear and to contact us, and then we're aware, we can have a discussion and to make sure actually that it is in the public interest. Our researchers also add the collaborators. So there's a lead applicant, and then if there's other collaborators who are accessing the data, the information on those individuals is requested. And then there's a material transfer agreement. So that's the agreement that forms the basis of the researchers accessing the data, and that's signed by the institute to ensure that all the kind of legal requirements of accessing the data are fulfilled. Researchers then are asked to select the tier of data. So rather than ask for particular variables, we know that it's not always completely clear before you start analyzing the data what specific variables will be needed. So we have this tiered system where the first tier includes all the survey data essentially and some of the biochemical assays, and then a second tier has some of the genetic risk scores and the imaging data, and then a third tier has some of the very large data sets. That's the whole exome and the whole genome, as well as the other data from the other tiers. And they each have slightly higher costs, although you'll see these are not prohibitively expensive for most institutions. This is a kind of cost recovery model. This doesn't cover the costs of running the study or doing the enhancements. It's only a kind of partial of that. It's kept deliberately low to try and encourage use. And there's specific support for groups that might have issues in accessing that funding. And then all those applications are reviewed by the scientific team to ensure that we are happy. The third step is that our researchers arrange for the payment of the fees, and the agreement, the MTA, is signed. As a fourth step, researchers are now required to complete some mandatory training. These are online modules. One is run by the Medical Research Council. The other two are within house so that researchers know the requirements of them, and then some introductory talks on the on how to kind of use the data. And so they do that and then inform us that they have done it and provide certificates, and they can then move on to the final step, which is accessing the data on the cloud-based platform. So they sign up to the platform, they then link their account to their sign-in, and they can start using the data. So until earlier this year, researchers could download some of the data. The size of the data set now is so large that the feeling was that in order to democratize access, it was important to bring researchers to the data rather than the data going to a select number of institutions around the world that were able to download and analyze it. There's also been the ability to do these analyses on the cloud has really changed. So there's both a kind of technical and a scientific rationale for requiring researchers to now only access the data on the research analysis platform. So in terms of requirements, the researchers must always abide by the material transfer agreement. They are also required to inform UK Biobank if they have conference presentations or publications that use the data, and they are reviewed by the scientific team. And then every year, each researcher is required to submit an annual report that includes an update of the research they're intending to do in the following year, the output of the publications that they have they've produced to ensure that they are using the data to generate scientific findings that are then made available to the scientific community, and that they are continuing to do research that is in line with their agreement. We now have over 20,000 researchers in almost 60 countries that are using the data set regularly. Most of those come from the UK, US, and China, and then a few other high-income, or a few high-income countries, and then a very small proportion from low-income countries. But we'd like to address that over the coming years. As mentioned, there's now 3,000, about 3,000 projects. They're mainly from the UK, US, and China, and then from a range of other countries, including Germany, with about 3% of the active projects. There's now over 10,000 peer-reviewed publications that have generated 400,000 citations and over 1,500 patents. And there's been a massive increase in the last few years, which I think reflects the growing scientific value of the resource. So I hope that's given a useful overview of those efforts really that we've made to try and address those key characteristics of large-scale, deep characterization, long-term outcome, and accessible as possible. I'd like to acknowledge our main core funders. That's mainly charitable and government, and also our industry partners, and of course the UK Biobank staff and our 500,000 participants. I mean, UK Biobank, in terms of the scientific team, is relatively small, and we really benefit from the wider scientific community who, because of the model, really take ownership of UK Biobank, and we have lots of working groups. We get lots of interested researchers who contact us, and we're very open to think about how we might enhance the resource for all users. So please feel free to get in touch with me or someone else in our UK Biobank team if you've got any ideas. Thank you very much.
Thank you so much, Ben, for this amazing overview. And in this series, we often had talks which had presenting the data in a few slides, but this is just impossible for the UK Biobank. It's just so much data. It's a little bit like a wonderland of data reuse, really. It's just so extremely impressive. So thanks a lot for also this very, very clear talk, which I think gives a lot of insight into the data, but also the potential.